In my opinion, I think that compared to the enormous amount of resource that is put into the treatment of primary prostate cancer, that men with recurrence after primary radiotherapy are a very neglected group.
The way we treat patients after radiotherapy has got to change. Traditionally, there wasn't much we could do for them if they got biochemical recurrence or a cancer relapse, and so we didn't follow them up very carefully because there was little point.
But now we actually have the realistic prospect of offering these men a treatment that can lead to long-term disease control.
We're trying to improve the care for these men so that they have a treatment option which has fewer side effects, but also may be more effective.
Radiotherapy is just one of the ways of treating localized prostate cancer, and many more patients used to have radiotherapy than they do currently, and even quite young men were having radiotherapy for their localized prostate cancer 10 or 15 years ago.
Radiotherapy is a good treatment. About 9,000 men every year in the UK have radiotherapy in this way. But like all treatments, sometimes it fails. About 1 in 3 men within 5 to 10 years will fail after their treatment. And currently, those men don't have many options available to them.
Radiotherapy by its very nature causes quite a lot of scarring around the organ that it's dealing with, but really it's the surgery afterwards which is very, very difficult because the prostate gland is shrunken, shriveled and stuck in place and extremely difficult to remove by open or indeed laparoscopic surgical techniques.
And the risks of incontinence can be as high as 60 to 90%, and the risk of back passage damage can be as high as 5 to 10%. So quite considerable risks to the patient if he chooses to have surgery. So most doctors don't recommend surgery and recommend watchful waiting with hormones.
Frequently, the patient will be monitored for some years, and the PSA will be allowed to reach a certain point, and then somebody will lose their nerve, either the patient or the clinician, and androgen deprivation will be started.
Hormone therapy is extremely useful for disease that cannot be cured, but hormone therapy is not a cure. It is just slowing down an already slowly growing disease.
Side effects are often quite severe. Patients feel very tired, lethargic, weak. The loss of libido can be very distressing for a lot of men. It causes weight gain and a redistribution of body fat, and a lot of men don't like the way that feels.
It causes the bones to demineralize, which can cause osteopenia or osteoporosis. It causes problems with the lipid profile, and we know that people on hormones have a higher chance of cardiovascular disease and cardiovascular death than patients who are not on hormones.
And most men, after 2 or 3 years of being on hormones, will fail to respond to the hormones. And then you're going on to a cascade of other systemic treatments, all of which carry side effects of their own.
And so if we can effect a local cure and stop them from having to take these drugs, then their quality of life is vastly improved.
In the past, people have investigated the use of various whole gland salvage treatments. People have looked at whole gland cryotherapy, whole gland high frequency ultrasound therapy, and whole gland brachytherapy, either high dose rate or low dose rate brachytherapy. These treatments are often associated with quite considerable side effects: incontinence, bowel dysfunction, impotence, pain, and even fistula formation. Some of those side effects, such as the impotence, are very frequent indeed. So I think most people think that whole gland salvage treatments should be restricted to very specific cases because the risks do outweigh the benefits. Focal therapies as a salvage treatment for prostate cancer can be delivered across a number of platforms, and these include high-frequency ultrasound, high-dose rate brachytherapy, and cryotherapy.
The most important thing about deciding who to treat for salvage therapy is to make sure, as much as you can do, that the recurrence of their cancer is in the prostate.
Over the last few years, there have been significant advances in diagnostic imaging, and this has allowed us to precisely map the pattern of disease within the gland itself, as well as diagnose patients with disseminated disease if it is there, even at low volumes. And this allows us to select the best group of patients that will benefit most from salvage therapy.
We've been looking at novel imaging to localize disease within the prostate. We've been using whole body MRI, choline PET CT scans, as well as bone scans, which are the traditional scans that most people use, to determine whether men have localized disease or disease that has already spread. We have to get it right, because if we don't, there's two things that could happen. Men could be overtreated, and in other words, the disease has already spread and they derive no benefit. Secondly, they could end up being undertreated. So they do have disease which is localized to the prostate, and they would benefit from a curative option that is targeted to the disease.
HIFU offers a chance of cure of disease with substantially fewer side effects than ever before, and indeed if we can do it in a focal way, or just treating half the prostate, then there's very little downside to it.
HIFU involves a probe which, under general anesthetic, sits in the back passage and effectively shoots very high intensity pulses of sound waves which heat up discrete bits of the prostate. And we can treat areas the size of a grain of rice, and we can be more effective in the areas of cancer that we treat.
When the patients are positioned on the HIFU table, we put a transrectal ultrasound in which gives you real-time imaging and also treatment ability. So you can look at the part of the prostate that you're interested in, map out exactly where you want the lesions to be, and then kill that part of the prostate by heating it up to 85 degrees centigrade. Generally speaking, the patient is either done as a day case or at maximum an overnight stay. They go home with a catheter in situ, and it depends on how much treatment you've done as to how long that catheter has to stay.
My particular interest is in high-dose rate brachytherapy, and at Mount Vernon Cancer Centre we have just started to pilot a treatment for salvage using focused high-dose rate brachytherapy. So patients go through the screening process, and if they are found to have a focal area of recurrence within the prostate gland itself, then we treat them using high-dose rate brachytherapy, which involves placing some interstitial catheters into the area of the gland that we want to treat. And we're currently treating these patients with 2 fractions of high-dose rate brachytherapy. The patient is treated usually a few hours after the implantation process. The treatment takes about 20 minutes. And then a second fraction is given the next day, then the catheters are removed. Usually the patient will go home a day afterwards. Focal salvage treatment options are still recent developments, and therefore we don't have any large-scale clinical trial data for their usage. In fact, in the salvage setting, it's always going to be very difficult to get large-scale data because there aren't huge numbers of patients coming up on a regular basis requiring salvage therapy. But in small single center series, we are seeing that focal salvage can certainly be given safely with very acceptable acute to medium-term toxicity. And over the coming years, we will learn about what the success rates are in terms of overall disease control.
Our program in HIFU started about 7 to 8 years ago, and almost from inception, we have been treating men in a salvage HIFU manner. Initially whole gland, and increasingly over the last 3 years in a focal salvage manner. With focal salvage HIFU, we have done a number of men now, and we've published these results in the journal Cancer. And what we've shown is that the risk of impotence is lower in men who still have erections after radiotherapy compared to whole gland salvage HIFU. The incontinence rate, rather than being 20 to 30%, is about 10% in this high-risk population. And the risk of rectourethral fistulae is very low. It's about a 1 in 100 risk, which again compared to 3 to 5% of whole gland HIFU and the 10 to 15% after surgery of rectal injury is considerably lower.
We have data stretching out to 6 years, and so although the median follow-up is only 3 years, we have some long-term survivors. At 3 years, we have up to 70% biochemical-free survival, by which I mean the PSA is less than 0.5.
In my experience, for focal brachytherapy salvage treatments, the acute toxicity has been very acceptable. I mean, all patients, once they undergo brachytherapy, have a period of weeks where they do have significant urinary and bowel side effects, but these are usually short-lived and self-limiting. And although we have picked our patients extremely carefully up to now, we have had no significant long-term problems from focal brachytherapy, which cannot really be said for the whole gland treatments of the past. Salvage treatments are currently offered in a handful of centres across the country. Some patients are being treated within clinical trials. In other centres, patients are being very carefully selected for treatment, and their progress is being monitored carefully.
I'm very fortunate that I work in a cancer network that supports salvage HIFU for radiotherapy failure, and both I and a couple of my colleagues regularly perform this procedure and have good results, and those are the results that we've published.
About 3,000 to 4,000 men who have undergone previous low doses of radiotherapy are still failing almost every year. And those men have potentially curable localized prostate cancer, which is recurrent after radiotherapy, who could have a curative option, such as salvage HIFU.
Our oncologists, of course, are extremely keen on us treating their patients who have radiotherapy failure. And it's very reassuring for an oncologist to be able to sit in front of a patient whose PSA is climbing, saying there is still a chance of a cure, and so sending them off to the urologist to do some HIFU. I would really like to see this roll out across the whole country so that more patients have the opportunity to be cured from their cancer when they start getting a PSA rising after their radiotherapy.